improved exercise capacity at a 1-year follow-up, but actually both exercise interventions improved capacity, just hit a little bit more. So with that, what do the guidelines say? Well, the 2010 ISHLT guidelines, which are due for an update, have a class 1 recommendation for routine use of cardiac rehabilitation. However, they do outline that there's a lack of evidence supporting long-term benefits, and there are no pediatric specific recommendations. The CST and Can Restore joint statement from 2019 also recommended cardiac rehabilitation, but again highlighted that there was a paucity of pediatric literature. So what are the current knowledge gaps in pediatric heart transplant recipients? There's a lack of randomization. There's no studies evaluating high-intensity interval training. There is a lack of home-based telemedicine interventions, and there's a lack of long-term assessments and sustainability. So that brings us to the MedBIKE trial, which is currently ongoing, where the primary objective is to evaluate the feasibility of a randomized crossover trial, evaluating a home-based telemedicine HIT exercise intervention in pediatric heart transplant recipients using a novel video game linked customizable cycle ergometer. And because that's a mouthful, it's called the MedBIKE. The secondary objectives are to evaluate the impact of the MedBIKE intervention on exercise capacity, physical activity, self-efficacy towards physical activity, and health-related quality of life. So what is the MedBIKE? So it's a customizable telemedicine ergometer that's linked to a video game platform. And it allows for networking of up to 4 participants per session. It includes a live bidirectional feed to the medical supervisor with video, audio, ECG, pulse oximetry, and the participant's work output. We essentially set up these bikes in their homes, and then we supervise them from the hospital or from wherever we are, and we can remotely modulate their resistance and their exercise prescription to ensure that everybody is having an achievable but challenging exercise every time. And this intervention is a 12-week program for 36 sessions, so 3 times per week. You can see they can bike around and steer and catch animals, but when they go into the high-intensity interval training, they enter this wormhole, which you see in the bottom figure, to disincentivize them from steering and just focus on pedaling. And they have a pedal power meter at the top where they get points if they keep the desired cadence up. So we've previously shown a strong agreement with the standard cardiopulmonary exercise test bike regarding power output and at a given oxygen consumption. And we also trialed this program successfully in 10 participants with Fontan physiology, so single ventricle congenital heart disease, and had no adverse events across 55 sessions. And then finally, we did the full program in 2 children with Fontan physiology and demonstrated improvements in their exercise capacity. So in this study, we're studying 10 to 18-year-old pediatric heart transplant recipients who are at least 6 months out. I included this exclusion criteria table, not for you to read, but to know that there's an exhaustive list like many other exercise interventions. So in terms of the participant timeline, they undergo a baseline assessment, and this consists of a cardiopulmonary exercise test, questionnaires, and an accelerometer to measure physical activity. And then they undergo randomization to either a MedBIKE arm or an immediate control arm. They then proceed with the 12-week intervention with a follow-up assessment after. For those that were randomized to the immediate control arm, they then cross over to the MedBIKE arm so that everybody who's enrolled gets the MedBIKE intervention. And then after that, we have 2 long-term assessments at 6 and 12 months following the MedBIKE intervention itself. Our primary outcome is feasibility. And so we've considered it feasible based on previous data if less than 1/3 of the 10 to 18-year-old heart transplant recipients at our center are ineligible, over 60% of eligible participants are enrolled, and over 80% of the MedBIKE sessions are completed with a less than 10% dropout rate. And we will modify the inclusion and exclusion criteria if we are not meeting these cut points. We also included safety as a primary outcome, which will be monitored, including symptoms of chest pain, ECG changes, arrhythmia, MedBIKE-related injuries, and profound desaturations. Our secondary outcomes include exercise capacity, measured mainly by VO2 peak, but other variables that I won't get into in the interest of time, as well as physical activity as measured by accelerometry, and health-related quality of life via questionnaire, and physical activity self-efficacy as measured by questionnaire. So the intervention is 12 weeks, 3 times per week, with all sessions supervised either by a physician or exercise physiologist. It includes a 5-minute warm-up, 4 high-intensity intervals that actually are 4 minutes each, 2 minutes each, and then a 2-minute breaks in between and a 5-minute cool down. And we target a heart rate response of 80 to 90% of their baseline heart rate max, as well as a Borg scale, which is a relative perceived exertion of 16 to 18. So currently, this is Health Canada approved, ethics approved, recruitment is ongoing. We're about midway through, and we anticipate completion within the next 12 months. This will be the first exercise intervention in pediatric heart transplant recipients with a randomized trial design that we know of. And if feasibility is established, we plan to expand towards a multi-center randomized crossover trial with adaptability to other solid organ transplant recipients and other pediatric populations. And a lot of that will be through support from CDTRP. So I'd like to thank you all for listening, and thank again CDTRP, Big Gifts for Little Lives, and the Evans Family Research Team grants in pediatric cardiovascular research.
Thanks so much, Michael. So now we'll move on to Dr. Janaudis-Ferreira's presentation. She is presenting virtually. If we could please connect her.
Can you see my screen?
Yes, we can. Thank you.
Okay, so good morning, everyone, and thanks for this opportunity to present the findings or the preliminary findings of our study entitled Acceptability and Feasibility of the Kidney Transplant Physical Activity and Social Club, the KEEP Active Club. I'm presenting it on behalf of our team. The co-PI of this project is my colleague Marie-Chantal Fortin, and we also received a grant from CDTRP, so we are very grateful. Thank you so much. Oops. Okay. All right, so we know that transplantation prolongs the lives of people with end-stage kidney disease. Sorry, there's things in front of my thing here. Let me see. Okay. But yes, we know that the kidney transplant recipients face numerous challenges after transplantation. One of the challenges is the high prevalence of comorbidities, for example, diabetes, hypertension, cardiovascular disease. And this is very concerning because we know that cardiovascular disease is the main cause of death with a functioning graft in kidney transplant recipients. There is also another issue that we know that the majority of the kidney transplant recipients face several barriers to engaging in and maintaining a good level of physical activity even years after transplant. And again, this is also concerning because this increases the risk of mortality and of developing poor graft function in these individuals. So we know that structured exercise and physical activity have been shown to reduce cardiovascular risk factors and improve exercise capacity and quality of life across many different chronic diseases, including transplant recipients and kidney transplant recipients. However, the problem is that there are very few exercise programs available for this population in Canada and actually worldwide. So this is information I retrieved from the Can Restore directory from our website. And we have a list of programs in Canada, and we could show that only 6 programs are available for transplant recipients in Canada, only in Alberta, British Columbia, Manitoba, and Ontario. And those programs are center-based, which makes it difficult for patients to have access to these programs if they don't live close to the center. In Quebec, for example, the only known program for kidney transplant recipients is a referral system to a kinesiologist. Again, talking a little bit more about poor engagement in physical activity, I've just told, and everybody knows, that those patients have low levels of physical activity. We recently, not recently, but in 2018, we did a survey with transplant physicians, and we found out that there's physicians are not counseling patients on specific physical activity programming. So this leads to low efficacy because patients are not hearing from other healthcare professionals either. This also leads to fear of movement, which itself has been associated with low levels of physical activity in this population. Another challenge that these patients feel or have, it's feelings of isolation and loneliness after transplantation. And here comes perhaps the role of peer mentorship that we are going to include in our intervention. So we found out in a qualitative study we conducted with these patients that kidney transplant recipients are highly supportive of a peer mentorship. Pairing mentees with individuals who have similar experience to provide, it's beneficial to provide training, information, and emotional support. And peer mentoring can occur during face-to-face meetings or electronically. The benefits are to improve patient empowerment, self-management, physical activity, and also there's psychological benefits for mentors and mentees. So this comes to our intervention. So we developed an intervention to support kidney transplant recipients to improve their levels of physical activity, improve their knowledge in cardiovascular disease and related risk factors, and break the isolation and loneliness that they may feel after transplantation. So this slide is just to show you that we took a very systematic approach to develop the intervention. We are using the ORBIT model for behavioral change treatment. We are this project falls into the phase of 1, which is define and refine the intervention. So we wanted to do this pilot work to refine the intervention, then continue to a proof of concept project, and then eventually do an RCT. We also use the components of the Bandura self-efficacy framework to map the components of our intervention with the components of this of the Bandura self-management efficacy framework. So the intervention, how did that look like? The Keep Active Club intervention offered 2 groups. We had an English and French group. We offered an educational session about cardiovascular disease and risk factors. There's also an online social networking. It was a closed Facebook group. We offered peer and professional mentorship, and we also offered a menu of options for physical activity. So there's no one specific exercise or activity that we offered to the patients. So the menu of options look like this. So we offered a pedometer-based walking program to them, or some examples of home-based exercises. And actually, in the end, this became a virtual session with our kinesiologist. They could also participate in the Refit for Life from the World Transplant Games Federation, and this program is available online. The Kidney Being online program from the UK, we could also have referred them to a kinesiologist if it was their preference. And there's also an open option where they could do sports or exercise programs in the community or fitness centers that were close to their homes. So the specific objectives of this study was to assess the acceptability and feasibility of the Keep Active Club intervention. We wanted to evaluate the pre-post changes in knowledge in cardiovascular disease and related risk factors, self-efficacy for physical activity, levels of physical activity, and social support and personal relationships, all to address those issues that I mentioned in the beginning of the presentation. So this was a pre-post feasibility study. We included adults with kidney transplant recipients that were being followed by MUHC and the CHUM here in Montreal. They could be in any time post-transplant, who spoke English and French and able to give consent. And we excluded patients who had any medical condition that would contraindicate physical activity. So we looked at feasibility and acceptability. As I mentioned, feasibility, we looked at number of eligible patients, the number of eligible patients that were approached, attendance rate at the face-to-face meetings, but in the end, because of the pandemic, this was virtual. We also looked at proportion of patients who have Facebook accounts, and we also aim to look at analytics of the Facebook utilization. We have not done that yet, but we are planning to do. And we also wanted to look at proportion of patients approached that accepted participation in the Keep Active Club, because the acceptability is a very important aspect of this project, or any intervention actually. So in terms of other outcome measures, we looked at the change in knowledge about cardiovascular disease and risk factors, again, self-efficacy, motivation and confidence, level of physical activity, social support, and satisfaction and participants' perspective. So I will give some data about the satisfaction. The interview, qualitative interview that we did will be presented, I think, as a poster during the meeting. So just to give you an idea, unfortunately, we start this study right when the pandemic was approaching Canada. So we start recruitment in February and March 2020. And not long after that, we had to stop, of course, but we managed to approach 58 patients, 19 agreed, 39 refused. Most of them because they did not show interest, or they did not want to deal with Facebook, they did not want a new account, or they didn't have a new account. And the other, it was also language issues. Then we restarted recruitment in December 2020. And we approached 55 patients, and 15 agreed, again, 40 refused, basically for the same reasons. And then 18 decided to participate, and 11 completed the post-intervention questionnaires and all the assessments. The patients that we included were, the mean age was 50, but a range of between 27 and 75. 50% were female. Time post-transplant was an average of 5.8 years, and most of the patients had comorbidity conditions, and the most common one was hypertension. In terms of level of physical activity pre-intervention, so most of the patients reported that they were not exercising regularly. And we asked also another question that was, compared to other people of your age, do you think that you are more active or about the same, a little less activity, or a lot less activity? Most of them said that they were less active, a little less active than people of their age, or a lot less active. So acceptability of the intervention, as you could see in the flow chart, was low. 33% was the acceptability rate when we did face-to-face recruitment, and 24% when we did the virtual recruitment. We strongly believe that this has to do with the pandemic, even though we switched the protocol to virtual protocol. But again, I don't need to explain how overwhelming everybody was, and also the community centers, pools, they were closed at that time. So I think a lot of patients decided not to participate because of this reason, but also they gave the reason of not being interested, or language issues and technological issues. For those who agreed to participate, all of them had a Facebook account. We had to help one open a Facebook account. Attendance rate, we had 3 virtual meetings, so 2 for MUHC because it was a larger group. In the first group, everybody attended. Second meeting, 56% attended, and there was same thing for the SHOM. 56% of the patients attended the virtual meetings, which included an introduction about the study, but also the information about the cardiovascular disease and risk factors. Most of the most common chosen activities were walking virtually with a patient partner, or classes with the kinesiologist that were offered virtually. We did not see an improvement in knowledge about cardiovascular disease and risk factors. So I think I'm not surprised, because half of the group in 2 meetings did not attend the session with this information. Motivation and confidence remained unchanged, unfortunately, and it might be related to the pandemic as well. However, we did see an improvement in self-efficacy, in readiness to change, which is kind of different from motivation and confidence, but it's still related. But we could see at least that 7 out of the 11 participants moved up at least to one category on the scale. In this scale, we have patients who are contemplating or preparing, or actually are ready to decide and take an action, or they are in the phase of maintenance. So most of the patients were able to change this category on the scale and becoming more prepared to exercise. The levels of physical activity improved using the EPAC questionnaire, and social support remained stable. In terms of satisfaction, 7 out of 10 said that they strongly agree that they enjoyed the intervention. 9 out of 10 strongly agreed that it was a good idea to do this program. 9 out of 10 said that somewhat or strongly agreed that they felt more confident to exercise after participating. All 10 participants strongly disagree that the Keep Active Club was unsafe. So they all thought it was safe. And opinion was divided as to whether the exercise program or the social interaction was the most important part or the best part. Again, I think the social interaction was compromised a little bit because of the pandemic. We were planning to do face-to-face meetings, and we were not able to offer that because of the pandemic. So Keep Active Club, we could see that it's feasible. However, acceptability is low, or was low in this context, possibly influenced by the pandemic, but we are discussing to see how we can improve acceptability in the next iterations of this intervention. And self-efficacy for physical activity and level of physical activity improved in those who participate in the intervention. So I would like to thank all our team members and CDTRP for the funding and the opportunity to present the findings. And I can take some questions, I guess, at the end of the session. Thank you.
Okay, well, thank you so much, Tania, for your excellent presentation. So we are going to reserve the questions for the end of the session with a Q&A. So next we'll move on to Dr. Dmitry Rozenberg's talk. Dmitry Rozenberg is a respirologist at the University Health Network and affiliated with the Ajmera Multi-Organ Transplant Program. He is an assistant professor in the Department of Medicine, University of Toronto, and has been awarded the Sandra Fair and Ivan Fecan Professorship in Rehabilitation Medicine. He began his studies in kinesiology and health sciences at York University, which sparked his passion for physical fitness and exercise training. He went on to complete medical school at the University of Ottawa, internal medicine and respirology training at University of Toronto. So thanks so much, Dmitry, for joining us, and we look forward to your presentation. You're muted.
Oh. Thanks for that kind introduction, and I'm going to share the screen for my slides, if that's okay. Perfect. I'm just going to put it on play mode. So good morning, everyone. So it's a pleasure to be here, and the opportunity. I'd like to thank the CDRP scientific community and the support from the CDRP for this project that's been ongoing for about 2 years now, looking at the feasibility of a home-based exercise program for managing post-transplant metabolic syndrome in lung and liver transplant recipients. It's a pilot randomized controlled trial, and this is in collaboration with my colleague, Dr. Mamatha Bhat. And so it's also published as well if you want to get a full sense of the protocol. So most, in terms of the post-transplant metabolic syndrome, it's a syndrome that's quite prevalent in our post-transplant population. It's comprised of impaired glucose tolerance, obesity, hypercholesterolemia, and hypertension. And it's prevalent across most solid organ transplant recipients at the 1-year mark post-transplant. So in liver, renal, and cardiac patients, it varies. The range is anywhere from 25 to 50%. And in our lung population, it's around 25%. And I'll show you some of the preliminary work that we've done to highlight the prevalence. And certainly we know that post-transplant metabolic syndrome, when you look at it at a population level, is associated with increased risk for hospital readmissions, cardiovascular morbidity, and decreased long-term survival. Work that Dr. with her group in the liver transplant population has shown that in a retrospective fashion that the risk of end-stage renal disease or major cardiovascular events was higher in those who developed pre-diabetes or post-transplant diabetes compared to the no diabetes group. However, no difference in survival was observed. Similarly, survival of patients with post-transplant diabetes and pre-existing diabetes significantly decreased at 10 years as compared to those without post-transplant diabetes in the liver population. So certainly that insulin resistance and diabetes plays a key role in renal function and some major cardiovascular events. Preliminary work from a trainee with our lung transplant program has looked at an older cohort through chart review of 2014 to 2015 patients were following up for 5 years. As you can see in red is the pre-transplant, the various metabolic risk factors from chart review, and certainly increases by the 1 year mark post-transplant, hypertension, hyperlipidemia, and subsequently at the 2 year. But the greatest increase, that inflection point, really happens at 12 months or so, where you have at least 2/3 having hypertension, hyperlipidemia, and 1/3 of patients affected by diabetes or obesity, and 1/3 or 25% have at least 3 or more risk factors. Something that we're working on writing up, but we did a survey as well, just to look at with Dr. Bhat, looking at the 6 to 18 months post-transplant period. What proportion actually are physically active or achieve the required, this is self-reported data, but what was interesting is we found that 7 out of the report participating in moderate recreational activities. But you can see under this red line, 15 out of 23, so 65%, actually were not achieving the recommended physical activity levels, moderate physical activity levels. However, the majority actually expressed interest in increasing their physical activity levels. And we know that muscle weakness, reduced exercise tolerance, and aerobic capacity are quite prevalent in the post-transplant period. And risk factors for metabolic risk factors include inactivity, immunosuppression, and muscle deconditioning. And we know that exercise training could improve insulin sensitivity, glucose metabolism, and increase transport of lipids to the liver and aerobic fitness. So we set out to look at the feasibility of undertaking a home-based exercise training study at around the 12 to 18-month period to evaluate the feasibility, so recruitment rate, program adherence, attrition, and safety, and satisfaction of a 3-month individual home-based aerobic and resistance training program in both liver and lung transplant recipients starting in 1 year post-transplant, and to assess estimates of intervention efficacy and elements of post-transplant metabolic syndrome, insulin resistance, physical fitness, and quality of life. And we hypothesized they'll be feasible to recruit both liver and lung transplant recipients into a home-based exercise program with more than 75% adherence, and physical fitness, quality of life, and biomarkers will be captured with less than % missing data. In terms of our study design, this was a pilot clustered randomized controlled trial of an individualized home-based exercise versus usual care, and aiming for 20 liver and 20 lung transplant recipients. And they do need to have at least 2 or more risk factors of post-transplant metabolic syndrome to be included at the 12 to 18-month mark post-transplant. We include anyone with active unstable cardiovascular disease, significant neuromuscular or orthopedic limitations, or someone who's too physically active, more than 150 minutes a week. And we approach patients through ambulatory clinics with our plan to actually do mailings shortly and randomize them to home-based exercise program versus usual care, which I'll elaborate further on. In terms of our exercise training group, this was a home-based exercise and resistance training program with a licensed kinesiologist at our center. And we targeted aerobic training 3 to 5 times per week for 12 weeks. And the reason we chose 12 weeks is we wanted to see if the HbA1c, which is a marker of diabetes and insulin resistance, would change over the 3-month period. And we provided individual prescription using an online physiotherapy program, Physiotech, which participants can engage in and get their exercises, and also the Teams platform, which is a standardized online virtual platform at our center. We targeted Canadian activity guidelines to achieve more than 150 minutes of moderate intensity aerobic training, walking or treadmill exercises, and we progressed their training from 65 to 80% of their training heart rate. Resistance training, generally targeting about 6 exercises of the major muscle groups. And we provide everyone with a physical activity tracker, 3 resistant bands, manual on exercise behaviors. And if they didn't have a laptop or a tablet, we could provide that as well. The usual care arm had counseling by the exercise professional at the start of the trial. They also were given a physical activity tracker. And after the study, the usual care group after 12 months were provided with a one-time counseling on exercise prescription in the home environment with manual. Both groups received 1 counseling session on healthy eating, consistent with the Canadian Food Guide by a registered dietitian. However, they could contact the dietitian throughout the trial at any time for additional questions or support they may need. In terms of our statistical analysis, and I do want to preface that the study is ongoing, so the results I'll present are only preliminary and not between groups, not to confound any interpretation to adhere to the appropriate RCT policy. So aim 1, we looked at descriptive statistics for feasibility for a larger randomized controlled trial, assessed the recruitment rates, program adherence, attrition, safety, and participant satisfaction. And we had 2 time points, baseline and 12-week assessments within and between groups, looking at PTMS and visual metabolic risk factors, HbA1c level, cholesterol, insulin, exercise capacity. And we aim for a sample size of 40, but 10 per group and transplant type in keeping with recommendations for a pilot study. This is our recruitment enrollment to date. As you can see, when we combine liver and lung, there were 131 from July 2021 onwards that we approached. About half of them were excluded for multiple reasons or difficulty getting a hold of them through clinic. And sometimes with the COVID environment, our clinical team had trouble sometimes asking patients in a timely manner. But the ones that we were approached, 69, as you can see, many we had trouble reaching despite multiple attempts. Number had declined to participate or dropped out, but we were able to randomize 14 to date and 4 are pending randomization. And so far we've had almost 14, 11 complete the study with 14 enrolled. So, and there have been no safety concerns to date. Some of the key challenges with recruitment that have been expressed and have observed by our team, it's the patients have expressed that it's the trial is a bit too time intensive, the 3-month period, so accountability and scheduling. Some participants we've observed are too sick, especially at the 12 to 18 month or managing acute medical problems. And so that's frequent exacerbations or admissions to hospital, something that we have to be mindful of. E-consent is difficult for older population, so it's something we're working on to make it streamline the process so it's easier, either through RedCap or email. And we've certainly observed the seasonal variation. So these patients may be more active on their own when the weather is nice and seeking more support during winter months. Some quotes of things that have been working well. Participants feel motivated and feel better overall. These are just some selective quotes. I stopped gaining weight and actually lost a few pounds. I'm also not as tired as I used to be. We had a qualitative questionnaire at the end, and feel stronger walking without a walker or a cane. The Fitbit of the 11 that have completed was well tracked in both arms, and participants enjoyed the remote aspect that they could do all of the blood work off-site, especially during the COVID environment closer to home across Ontario, that they didn't need to come to the hospital to do the blood work that we needed at the start and end of the study. However, there are some ongoing challenges. So issues with connection and technology still continues to be a problem for some participants, and we work with that and through phone as well. And some participants have found that there's quite a lot of documentation, both on the study logs, and I've expressed that trying to minimize that as well. And certainly the motivational aspect has been challenging for some participants that expressed during illness and the COVID environment. Something that our study team has also observed is the remote exercise training is working well. The participants like the exercise bands, learning how to use them and being able to keep them to continue the training. Weekly meetings for 3 months may be a little bit too much, allowing participants to have a bit more independence and perhaps going to bi-weekly meetings and considering including more educational topics related to post-transplant metabolic syndrome management. So certainly we provide them with a booklet at the start of the study, but reinforcing other key aspects and throughout the study on healthy eating, sedentary time, relaxation, and stress management. So more multidisciplinary approach, and patient like having access to nutritional support that's been expressed. So To conclude, a home-based exercise program may prove to be an effective post-transplant intervention for improving the metabolic profile of recipients and characterizing the feasibility, adherence, and effect estimates of home-based exercise training constitute the first key step. And these preliminary results will help us develop future studies aimed at reducing the morbidity associated with PTMS. I'd like to thank the study team and who've helped, as you can see, a number of key players, the CDTRP research support and funding, the participants in the study in the Merit Transplant Program, and other funding support that made this grant possible. Thank you once again, and I will turn you over to Dr. Mamatha Bhat for any questions you may have.
Okay, thanks so much, Dmitry. So now we'll open the floor to questions, and Manuel, if you could please let us know if there are any questions in the chat.
Hello, Linda Powell. All of the studies presented have talked about exercise programs post-transplant. And do you know of any research or thoughts on the longitudinal study of seeing people perhaps who are waitlisted, pre-transplant exercise programs, and how that influences outcomes?
Yes, for sure. So Michael, would you like to?
Oh,
take
maybe
that?
we can go along the child and adult continuum. So
Yeah, and then Dmitry also could.
yeah, so
contribute to that.
in the pediatric literature, I don't know of any studies that have looked at that, but that would be a very important question. Sort of the prehabilitation piece prior to transplant would be important. There are aspects of listing a child for transplant that are a bit different than in the adult world, and so sometimes there's a bit more of a sense of urgency or less opportunity for prehabilitation, but it certainly is something that would be very important. So there's nothing in the pediatric literature I know of.
Okay, Dmitry and Tania, would you like to comment?
Sure, Tanya, you want to go first? You're doing some pre-rehab.
Yeah. Well, I think that's a very good question. And yes, I've done a systematic review on this topic. And I think I can say also there is very limited literature in adults as well in terms of prehabilitation. There are more papers, more articles for sure. What we know is that prehab can improve exercise capacity of transplant candidates in different organ groups, quality of life, but there is no prospective study that actually looked at how an exercise program before transplant can impact post-transplant outcomes. So, and there are very few randomized control trials in this field. So this remains a very important question that we need to answer. There's a couple of retrospective review that show that exercise before transplant can reduce the number of hospitalization or number of days in hospital after transplant, but those were retrospective studies.
Okay, yeah. Dmitry, would you like to comment?
Sure, thanks.
To echo what the gallery view so that we can see everyone.
All right. Just to echo what Tanya had mentioned, yes, there aren't too many RCTs, randomized controlled trials in the pre-rehabilitation phase. Certainly they're needed. Some of the challenges in the pre-rehabilitation phase is a lot of programs have some clinical programs, but the uncertainty of when that transplant will come and the duration. And so I know a lot of researchers have shied away from that important question because it could sometimes that pre-rehabilitation phase could be 3 months or it could be 12 months or 15 months sometimes. And so but certainly doing a longitudinal study where you start pre and kind of follow them out to let's say a 1 year post-transplant or 18 months would be a large undertaking, but potentially needed to help understand some of those early post-transplant functional recovery elements. So that's all I'll add. Thank you.
Yeah, I know in the lung transplant program, there's been at UHN, there's been lots of work on the pre-side, and you've been involved in that, Dmitry. So I think it would be very interesting to look at that continuum from pre to post in the longer term. I know that Leanne and Sunitha have been actively involved in such studies. Okay, great.
For sure. There's a lot of observational studies and some of even from our traditional standard of care at our lung transplant program is to do exercise training with a hybrid approach in person or virtually. until transplant and then 3 months post-transplant. And there's been a signal showing that individuals with a higher 6-minute walk distance, so exercise capacity, have an inverse relationship with hospital length of stay, and also some quadriceps strength. So these are observational studies. Some have been retrospective, some have been prospective, but not specifically to rehabilitation. So more observational in nature of our outcomes.
Okay. Thank you. So we have a question from Rink on the floor here.
Just a follow-up on that is, from a patient perspective, one of the big challenges we have is to get onto the transplant list is a challenge. You have to be bad enough, yet good enough. Good enough in terms of healthy enough to be able to sustain a transplant properly, but bad enough to be able to make the criteria for getting on the list. It's like the impossible problem to solve. So what happens is, and the other thing is you don't want to go to hospital. So you're trying to avoid going to hospital because you might get sick going to a hospital. So they suggest, okay, you should stay home. What happens as you're, I'll say, gracefully trying to degrade to get to that point, to that sort of point where you are actually going to get on the list, it's very hard to figure out how to solve that. So one of the things is, I mean, the exercise, the things you're talking about are absolutely spot on. But it's that journey is what are the key points that you need to address from a patient perspective as your objective? Your objective, maybe get on the transplant list without dying first. So it's more complex than that, I think. So it's about analyzing the parts of the journey that are critical to a patient. And so, again, stay healthy enough, yet be bad enough at the same time. And I think trying to solve that, I think, is really important. So that's my only comment.
Yeah, no, that's an excellent comment. Actually, in liver, end-stage liver disease, we see so many patients who get more and more frail on the waiting list, and certainly having access to prehabilitation programs would actually help in keeping them well enough to benefit from transplant and to stay fit enough for transplant. So unfortunately, we don't have the resources to do that, but it would be ideal to have such resources so that people could stay well enough and fit enough for transplant while their MELD score goes up, right? Yeah. Thank you. Elaine.
Hi, my name's Elaine. I'm a PFD and the mom of a heart transplant recipient. So my question's for Michael. A few questions. One, and maybe I missed it because it was a little bit late, the cost of the MedBIKE. Obviously, this is not a program that is going to be, I think, in terms of longevity and number of participants, I assume that it's probably cost prohibitive to give every child a MedBIKE. So what the findings that you take from this study, how will you translate that into everyday life for transplant recipients everywhere? And then the other question I have is around looking at endurance, because I think one of the things we've seen is that my daughter is very physically active, but when it comes to long distance running, for example, or swimming for a long distance of time, she just can't sustain it. So how are you measuring that? And, have you had observations about that already?
Yeah, these are important questions. Thank you for asking them so that I could touch base on this in a little bit more detail outside of sort of the confines of the 10-minute talk. So you're right that a MedBIKE in every child's home is likely prohibitive unless the CDTRP wants to be very generous. But that is not the goal. The goal is not only to improve exercise capacity as a result of an exercise intervention, but to dramatically improve self-efficacy towards exercise, such that they are incentivized to take on a more active lifestyle and maintain these changes. And so that's why one of our leading secondary outcomes are the 6 and 12-month follow-ups when the MedBIKE is out of the home to see, and we measure self-efficacy, physical activity levels, but also exercise capacity at those time points. This is not something that's been studied well in the pediatric literature, transplant or otherwise, long-term follow-up. But our hope is that we can maintain self-efficacy long-term, and we'll study that very question. outside of that, there's a potential hope to be able to get med bikes into community centers, or accessible in sort of regions or clusters of populations, so that our geographically dispersed patient population doesn't all have to come into the hospital, but rather can access the exercise intervention, or they can have cycles of med bike intervention throughout the year at different time points. Dmitry had nicely pointed out that participants often need more support during winter months of strategies to be physically active. And so those are all things we've considered in case we can't get their self-efficacy up to exercise on their own. To answer the second question, endurance. So we have a number of exercise capacity measures that we're going to evaluate, including peak oxygen consumption. But one of the measures that often is associated with endurance is their oxygen consumption at the anaerobic threshold, which is often used for generating an exercise prescription. And so theoretically, if we saw an increase in that would associate with endurance, but we're also looking at power output and peak consumptions and respiratory efficiency. So hopefully those measures improve and we can see that in real life with the kids as well.
Okay, thanks, Michael. Please go ahead.
I'm Jennifer Kingdon, also a heart transplant mom. And what was on my mind while you were talking in each of the studies was how we could involve patient partner in the research in the initial stage, in terms of asking the question, what do you think would be most effective? What would be strategies that you think people would be interested in? I think a lot about the heart transplant or the transplant games. It's peer-to-peer motivation and incentive that I think motivates and encourages people to participate. So when I hear the adherence, even in some of the strategies that were initiated, I wonder if patient partners could be involved even in the implementation of some of these programs. For instance, the Facebook groups, to be part of the I suppose inspiration of that as well. There may be a little more adherence to the program if they feel like this is something that is advocated from a peer-to-peer perspective. I don't know. It's just something I thought might be helpful.
Yeah, thank you. I'll just quickly say that we did have patient partners in our, that's the Big Gifts for Little Lives group, and they've been instrumental. One of the things the kids love is the video game aspect, but also you can have up to 4 kids at a time exercising. And so they actually see each other in this world and they can sort of pseudo compete or crash into each other or whatever it is. But they enjoy it, and you're spot on for sure.
Okay, thank you, Jennifer. So we'll take one last quick question from Shilpa.
And not so much a question, but a comment. So I'm 10 years post double lung transplant. And as you spoke to, like the physio program prehab, post lung at UHN is fantastic. And I think like the keeping fit while you're waiting, sort of maintaining any function that or physical strength, ability, whatever, going into that transplant is so key. That's a huge part of it. But the other piece I think touched on a little bit here and there was around the community, the benefits to mental health and having a community around transplant. So the people that you waited with or in the physio room, we would be in there 3 times a week. Those are your peers. Those are the people you speak to. There are people coming in post-transplant, so you'd see them after to be able to hear what the process was like. Even the people you're waiting with, like we would do things like games nights or movie nights, and people who are coming from all over, especially for lungs, coming from all over Canada, especially the East, and waiting in Toronto where they don't have necessarily a social network or other people to speak to. This becomes your community. And the benefits of that for both the patient and the caregiver who's also coming into these appointments and the physio sessions, I think was immensely beneficial. And then that community is sort of what you have post-transplant as well. The peers that you kind of keep in touch with, the people that I went through that process with are still either the ones who are still alive and thriving or still a part of my life now. And the people who've passed on, their partners still are very much in touch with us and are, care about what happens to us. And it's just like that part of the prehab is equal. I felt equally important to the physical training and strength maintenance, I guess. So yeah, I just wanted to shout out to that as well.
Okay, wonderful.
Yeah.
Well, thank you so much for sharing that. I think, beyond the physical functional maintenance and endurance building, beyond that, the emotional and psychological benefits of, working together with your peers towards that goal and, towards transplant and beyond. Really, thank you for sharing those thoughts. Yeah.
I might just I know we're over time, but I want to emphasize how incredibly important that comment is, because as there's an increased interest in telemedicine exercise interventions, which I'm part of that increased interest, and I know Dmitry, amongst others, is leading a working group on working on this. But one of the things is to translate the benefits of in-person facility-based exercise interventions, including the peer-to-peer connections, and to find ways to make sure that we maintain that. So thank you very much.
Okay, well, with that, I'd like to thank the speakers for an excellent session. Thank you, Dmitry and Tania, for joining us, and Michael for your excellent talks, and Wajiha as co-moderator. Thanks so much.